The title is How a Simple Ankle Sprain Can Change the Rest of Your Life. Now, the reason why it's misleading is because this is really not about ankle sprains. In this topic, we're discussing ankle sprain, but notice where that injection is. That's not near the ankle. So what we're looking at is how an injury, like an ankle sprain, can impact and cause other pathologies down the chain. And if we don't find out via history what the original injury was, we're going to miss the underlying pathology. We don't want to treat the pathology in front of us only. We want to treat the pathomechanics. So today we'll be looking at biomechanics and making sure we don't miss anything. And in that, we'll be looking at ankle sprains. So having said that, if you guys don't mind, make sure you mute yourselves just so we don't have the background noise. So the first question is, what is the best predictor for any type of injury, right? The best predictor for any type of injury is a previous injury. So when you ask your patients why they are coming in, they might tell you it's for their knee, for example. And then you ask for previous injuries, and I can promise you, if that patient had an ankle sprain, a good portion of them will forget to tell you about them. Because in society, we call ankle sprains just typical. So make sure you take a really clear history and make sure you ask them about ankle sprains, because that could be one of the diagnoses that we miss. And the goal today is to talk about, if left untreated, an ankle sprain, for example, untreated properly, what impacts are down the road due to this kind of injury. And the question is RICE the proper treatment? Rest, ice, compression, elevation. Is this really the best treatment? It's great for acute injuries. That's what I was told when I had my ankle injury in college, but that's temporary. And then proprioception training. Is that what we do? Do we do strengthening? Is that what our focus is? Really, that's all true, all helpful, but we have to look at foot and ankle biomechanics. So today, we're gonna dive deep into biomechanics and how we can look at that to help prevent injury. And if we don't, what happens is a cascading chain of events that had a huge impact on my life, and I'm sure have had impacts on your patients' lives. And maybe they don't even realize it. So let's just talk about some anatomy first. Let me see, since we're not in person, let me see if this will be a little easier to show in pictures. Can you guys see this? So if you look at the anatomy here, I want to go over some of the main areas we're looking at, right? So bony structure-wise, we want to look at the tibia and fibula, okay? So this is the mortise over here. So the mortise is essentially where the tib fib come together and articulate or meet up with or move along with the talus. So the talus is right below the tibia, right? Fits right in there. And then we have the navicular. These are very important. I'm not going to go over every bone, but I'm going to go over the bones we're going to be talking about for this presentation. And the cuneiform, this is the medial cuneiform. And the first metatarsal. And the phalanges to the big toe. Now this right here, this section here, this is really important. That's what we're looking at a lot when we talk about the pathologies today. Now, obviously, it's going to impact other joints. All these are the three cuneiforms. You know, you have the cuboid. When you look at the back of the foot, you have the calcaneus and talus is the subtalar joint. There's a slight amount of inversion and eversion right there. So these are the muscles that we're looking at as well. So some of the important muscles, if you look here, this is peroneus longus or fibularis longus. Notice how the muscle belly, belly's up here. You got pain up top. You could also have pain along the lateral You could also have a problem where it goes through a groove here at the cuboid. And then if we go underneath, where does it go? It attaches the first ray. So the first ray attachments, this helps when it's rigid, helps support the arch. So we're looking at that. We'll talk about that a little bit with cuboid syndrome. We're also going to be looking at the posterior tib. Let's see if I can get it to visualized here. This is the posterior tib, right? It goes along the medial tibia, and look where it attaches, all along underneath the foot. This really holds up the arch. So when you have a pronator, someone who excessively pronates, that posterior tib is working very hard to hold the arch up. And the other tendon and muscle structure we're looking at is the flexor hallucis longus. And you can see again, it runs underneath this medial malleoli and goes to the end of the toe for flexion, but also can restrict extension. Okay, so those are the structures that we'll be talking most about. All right, so let's go back to our presentation. All right, so let's talk about the case study. The case study is me, okay? The idea is I had this injury back in college in the 90s, so I was going to PT school. I had a severe ankle sprain my junior year in college. And the only thing I had done was x-rays, and the x-rays ruled out a fracture. Okay, that's pretty typical. I played collegiate pro volleyball for the next 20 years. That's probably why I had continued issues. If I did nothing for the rest of the 20 years, maybe I'd be in a different place right now. But just to give you an idea, my story is not so different than other patients that you've had. And basically, I had a pain progression from 97 through 2015. And the pain started at the anterior medial talar dome, okay? That is where I had talocrural impingement. That's what we see a lot in the clinic. Patients have pain right over that, medial talus. And when they go to dorsiflex, when their shin goes down over their toe, they feel that compression pain. We treat that all the time, right? Now, what I didn't know for sure was that I had a defect, an articular defect. That was one of the things I think that was missed. And we'll talk a little more about that. But what started as medial pain in my talocrural joint ended up as intermittent pain over my cuneiform and first metatarsal, which turned into an exostosis, which we'll talk about more. That's bone spurring at that joint. All of this is a progression, a biomechanical progression. And we'll go over all that. Now here's where things changed. I never had any pain in my forefoot. This is all midfoot that we had pain in, right? In 2018, we had a PT come in for one of our education seminars, and he said, "Oh, we need to put a medial post. That's a wedge under your medial forefoot." So I said, I didn't agree with it. I didn't really think that was the way it should go, but I did say, okay, let's give it a shot. Why not, right? So I put that there, and it didn't go very well. Within a few months, I started having significant pain to my third and fourth metatarsal. I removed the post, probably left it in too long, and I was diagnosed with a possible Morton's neuroma, which we'll talk about. There was significant pain with walking. So this is forefoot pain. I couldn't walk barefoot. I would get out of bed every morning, and I had to put my sneakers on just to walk. I'd be limping. And I basically, from that point forward, had sort of a step 2 gait pattern where you don't want to push through. You just want to step up to your toe, and then a mid stance, sort of pick your foot up and step again. So you don't want to go to push off. And that was the only way I could really walk. So what the theory was that maybe I just had irritation of the tissues there. Maybe it was an irritation of the capsule. Maybe it was an irritation of maybe a neuroma. So what we did was we did a cortisone injection. Now the question is, did it work? It worked temporarily, but remember, cortisone can have great benefits, but if you're not fixing the mechanical issue and you keep stressing something over and over and over and over again, no matter how much anti-inflammatories you pump in there, it's going to come back. So without looking at the biomechanics, assuming it was just an irritation that would go away, it just returned. And eventually the pain ended up in my second metatarsophalangeal joint. By the way, I suggest you take off your shoes and socks because you should be feeling your own foot. And I'll go over a couple things that you might want to do, but air those feet out if you can. But the second MTP joint, every time I push off, it caused significant pain through there. And so I tried prolotherapy, which is basically injecting an agent that scleroses a tissue. So if you have a hypermobility, a joint that moves a little too much, you're able to theoretically tighten the ligaments to certain capsules, plantar plate to a certain degree. So that didn't work. PRP, platelet-rich plasma, same idea, did not work. Of course it didn't work. It was a mechanical issue. So it was still going to break down whatever benefits those treatments did. So just to give you an idea, this is a few years of pain, okay? And here's the treatments I did without any effectiveness. I did orthotics. I did orthotics with multiple changes. The podiatrist even added on certain things to the orthotic, which didn't make a difference. I did gastroc and soleus stretching. I did first MTP, metatarsal phalangeal joint moves. I did balance foot and ankle stabilization exercises. I did eccentric calf strengthening. I did plantar fascia tissue work of all kinds. I even tried to change my gait to focus on pushing off my first metatarsal phalangeal joint. I did the injections. Now, if you look at those treatments, I would say, in my opinion, if you look at the gold standard, those are them, right? So everything in there is what we do typically for any type of foot pain. And none of it worked. The one thing I was missing is I never really took the time to look at the biomechanics of my own feet. And that's the issue. So if we look a little deeper and treat a patient specifically for their biomechanics, we can make much bigger changes, which is exactly what happened. And I'll describe how basically one manual therapy treatment eliminated my pain. And we'll go through that after this.
Kahl, can I ask a question?
Yes. Yes.
Sorry. Right or left foot?
Left. Left ankle. So basically, it was left ankle sprain, everything followed on the left-hand side. So basically, just to give you an idea, we have 23,000 ankle sprains per day treated medically. And they hypothesize that probably 50% of ankle sprains aren't even treated medically. They don't even go to the physician or the PT for it. So we can have, you know, over 45,000 ankle sprains per day. That's a lot of ankle sprains. And if you think about our practice, how many ankle sprains do we see? Not a ton, not compared to how many ankle sprains occur. I think that's because we just assume an ankle sprain, hey, it heals. Well, the answer is yes, it does heal. Because what are we looking at? We're looking at ligament injury, right? These ligaments, of course, they scar down over time. So there is, yes, they tighten up. But what are we left with after the ankle injury is the question. So let's quickly go over what we have here. You have the anterior talofibular ligament, right? Obviously, that's the one sprained most often. When you plantar flex your foot and invert, you pull through here. You have a little bit of calcaneal fibular ligament injury, right? That goes right through here, and that's injured. That could be grade 1. More intense could be grade 2. And then grade 3, you impact on the posterior talofibular ligament. Now, this is less likely to get injured. The reason why is in order to get to this ligament, you need to be in much higher dorsiflexion to really stress that ligament. And when you dorsiflex more, that's when you actually are close packing the joint, so there's less mobility. It can happen in severe ankle sprains, but it's pretty severe when you impact that. Mine, I believe, was affected because you know what I have now is I have bone spurs right over here. Why do I have a bone spur? Well, bone spurs, due to Wolff's Law, are there because of excess force. Excess rubbing, pulling on bone can cause more bone formation. There's a high likelihood that there was an injury there and I had a grade 3 sprain. We'll also talk about, so much time we have, talk about cuboid syndrome. Very interesting and something that we don't want to miss. Here's where we don't really look at things. And this is where we think it's just an ankle sprain, it's just ligament. But what we need to make sure we understand is even with any severe ankle sprain, when you have an inversion ankle sprain, what happens is you make contact between the talus, right, the medial talar dome, and the tibial plafond, right? Once these make contact, what's next? Now you dug into that articular cartilage that covers the bone. And this articular cartilage lesion can turn into osteoarthritis. I think what's important to realize is that 75% of lateral ankle sprains lead to chronic symptoms. So think of those numbers. If we're looking at, 20,000+ a day, and 75% of them lead to repetitive sprains or chronic symptoms, something more is going on. And this is probably what we're looking at. Now, this is interesting. Studies show that up to 90% of arthritic changes are due to trauma. Now, that might seem obvious, but if you look at the knee, 2 to 10% of arthritic changes in the knee are due to trauma. So I think it's really important to recognize that trauma is what's causing articular defects, and that leads to osteoarthritis. So here's an X-ray showing the defect, and evidence says or suggests that if we intervene early, this will allow us to possibly modify the course of the osteoarthritis. It's our job. When we see an ankle sprain, we need to make sure that we are looking as deep as possible at the mechanics so we can prevent the osteoarthritis from occurring because of a postural lesion. So let's get to the PT side of things. Let's talk about equinus foot. Equinus foot is basically a limitation in dorsiflexion, right? We see it all the time. You have a patient come in, they're limited in dorsiflexion. Why? Could be multiple reasons. It could be bony reasons where you actually compress anteriorly. It could be reasons posteriorly where you actually have soft tissue restrictions in the calf, gastroc and soleus, for example, that limit dorsiflexion. But either way, it's a dorsiflexion restriction. This is our bread and butter. We see it all the time. This is what we treat. Now, this is an actual patient of mine. I mean, check out her arch. This is her normal resting position. She's not pulling her toe up. This is exactly how she is at rest. Now, let's talk about her. She was a pro volleyball player. She played in college and played pro indoor volleyball. And then she progressed to beach volleyball. She ended up being one of the top volleyball players in the world. When I was treating her, she already had multiple injuries. So let's talk about what those multiple injuries are. Number one, sesamoids. The sesamoid is right here under the metatarsal, right? What she had is she had bilateral sesamoid fractures. I want you to think about that. Why would you have bilateral sesamoid fractures? What they did was they ended up putting little cutouts, pads, over her metatarsal, so that would actually give her some shock absorption there. And that can help. But does that treat the problem? What's the problem here? Can you see her arch? This is a rigid, supinated foot, right? She has a equinus foot. She definitely doesn't have full dorsiflexion. So when she jumps and comes down on her foot, what points of contact are there? This is the point of contact, and this is. When you're jumping with 5 times your body weight down onto a hard surface, what's going to give? Probably that sesamoid bone. And what would I do to treat her if I had her back then is I would try to work on pronation, because pronation is very important. You need to bring that arch down. That is what pronation does, is absorb shock, to distribute the force to the whole foot, not just here and here. So what else happened to her? Think about this. You're playing volleyball. Your right foot's on the ground, right? Plant your right foot down. And now you have to turn over your shoulder to the left to back away from the net. So as you're turning, you're trying, what should happen is this foot here should come down into pronation. When this comes down to pronation, guess what happens to tibia? It internally rotates, okay? It comes down. So when this comes down here, this should internally rotate. But it doesn't. It doesn't internally rotate. Unfortunately, it's fixed. This is a fixed tibia on a fixed talus. So what happens instead is you have a femoral internal rotation. So what happens when you internally rotate your femur and pelvis? The entire femur and pelvis internally rotate, and think of the attachments. You have this big quad that goes over the patella, that attaches the patella ligament, that attaches to the tibial tuberosity on the tibia. Well, your tibia is stationary. Your tibia is not moving into internal rotation. It's not going with you. But your femur is. Guess what happened to her? Patellofemoral dislocations. Bilaterally. Not the same day, but both sides happen. Why they happen? Because of this rigid arch. We treat her for patellofemoral pain, and we were able to eliminate that pain by treating her foot. Okay, not her knee. We did treat her knee a little bit, but really it was treatment of the foot. That was the key. So we have that rigid foot pathology. That's one type of equinus foot. The other is what you see below. This is the flexible foot, right? This can cause excess pronation in the midfoot. So let's look at this. So here is the foot, just a neutral. Already, this is a flat pancake foot. This looks more like my foot. Not mine, because I don't wear the polish, but this is more like my foot. Now, when this person, when she dorsiflexes, notice what happens. See her heel comes off the ground? How much motion's there? Not much. And what happens? Here's her tibia, here's her talus. Where does that breakdown occur? Right here. So here we have talus, navicular, cuneiform, first met. Where's all that force go through? Right here. One of the breakdown points could be where the cuneiform meets the first met. And that is what I had. And I'll describe that the next slide. Another example I had was I was treating an NFL superstar linebacker. He was the most feared linebacker in all of football at the time. And I basically was treating him on one knee. He had reconstruction, and he did great. That knee did 100%, never had a problem with it. That was a straightforward, made it happen, excited we were able to do that. However, when I was treating him, I pointed out, I'm like, hey, I know this is not the same side, but I want you to know that you have a significant dorsiflexion restriction on the other side, and your foot mechanics really aren't good. They're better on the side that you tore those ligaments on. And I said, I really think we should treat it. Now, when you're treating somebody who's worth millions upon millions upon millions of dollars, you need to get permission, right? He was adamant. He's like, hey, dude, ain't broke, don't fix it. And you know what? That's what you do. You say, okay, that's a lot of liability. I'm not going to do something you don't want me to do. So we didn't touch it. Guess what happened a year later? His knee did great, but he ended up having Achilles issues that turned into a severe tendinosis, never had a rupture. And that Achilles tendinosis ended his career. He had a huge career. That ended it. There's a possibility that we treated his equinus foot, we might not have had that problem pop up. So we won't know, but that is essentially biomechanically what we would expect to see in a breakdown. So if we go back to that flexible foot that we talked about before, what happens is when you have a restriction and you can't get a full dorsiflexion, what happens is all the motion, remember this flattens out and all the motion occurs right here. So bone spur occurs. This is the exostosis or saddle bone deformity. So now, this is not my foot. This is just one of the clinical presentations I found online that shows exactly what I have on my foot. That exostosis or bone spur is there. Take a look for that in your patients. If you see that, you know there was excessive movement or force through that area, which probably means that a dorsiflexion restriction and how to compensate, and the compensation occurred right there. So this is one of the second parts of what I started having. Your body's always gonna move away from pain. When it moves away from pain or restriction, you're gonna make up that movement somewhere else. This is where it was made up. So really important, we wanna keep in mind regional interdependence. In this case, we look at a restricted talocrural joint. Motion has to occur somewhere else in another joint. When we went through our certification program through the SFMA, which is a great program, we look at regional interdependence. Well, this means that one joint affects the joint above or below, right? So here, for example, ankle. What do we want in ankle for dorsiflexion? We want mobility or stability? We definitely need mobility. We need that dorsiflexion, right? We need plantar flexion. In the knee, we need stability, right? Usually it's moving too much. We need stability here. In the hip, what do we need? We need mobility. In the lumbar spine, we need stability. Thoracic spine, all those movements we're doing in the clinic, we need mobility. Cervical spine, we want stability. We move through that mid-cervical spine and cause issues. Upper cervical, we need mobility. That's how we get that half that motion and rotation is through AA. So it's really important for us to recognize that every joint impacts another joint above or below. So going back to my issue, okay? I was diagnosed with the Morton's neuroma. Well, why? Now think about this. This is my third diagnosis. Now I have a Morton's neuroma. Is this neuroma my true diagnosis? Or is this just a product of the biomechanical changes that occurred in my foot due to my ankle? Well, that's what we need to look at. Do I want to treat this? Yeah, but not really. I want to treat what the cause of that is. So what we want to be careful of is structural, looking just at structure. Structure doesn't dictate function all the time. So for example, I have what's called Morton's toe, and I bet a lot of you do also. 40% of us have Morton's toe, but if you look at the research, it says this Morton's toe, this longer toe than the great toe, this longer toe, and usually there's the web space is less than the rest. This longer toe predisposes you to excessive force through the MTP. So what does that mean, right? That means that because of this longer toe, you have this. Yeah, but I have a Morton's toe on both sides. Bilaterally, I have the exact same thing, but why is it my left side? So if we only look at structure and say, hey, look, you have this over here, you gotta look bilaterally. Biomechanics will impact structure. This can predispose you to something, but if it's not bilateral, what's going on? There could be a biomechanical issue. And that is what I believe I had. So here's where it gets interesting. After time, this is years and years of pain, I was diagnosed with early stage of FREÍBERG'S disease. This is essentially when you put so much stress through this second MTP joint, it causes microtrauma and eventually could lead to a vascular necrosis. This is basically the disease process where you have a blood supply issue and it could essentially need surgery. And when the podiatrist told me that I was a possible candidate for an arthrotomy or an osteotomy, an arthroplasty, that's when I was done playing around. That's when I said, okay, I need to figure out exactly what's going on. I am not okay with the possible surgery. So I stopped doing the basic treatments and I started thinking of what can I do, right? This is when you each should have your shoes off, and this is when you should try a few things. So I'm gonna tell you what helped, and I'll tell you how I diagnosed myself, how you could diagnose your patients and you. So after this moment of me realizing that I really need to figure this out, I need to check my gait. Now, the gait we usually see, that I expected to see when I did slow motion analysis on myself, was a medial heel whip. This is when your heels come in toward your body, right? When you see that, there's usually some kind of mechanical changes that aren't good. We'll talk more about detail later. And guess what? There was no noticeable difference. So I want to caution you. Just because you don't see a significant medial heel whip on one side over another doesn't mean the mechanics are okay. So I just want to put that out there. Now here's where it got interesting, where I wanted to check my mobility in my first gray. So if you sit there and you take both feet, you could actually put your thumbs over your navicular. So go sort of on the inside of your arch. Take your thumbs over your arch, right, toward the back side a little bit. And then that's under your foot on your arch. And then take your fingers and put them on top of your great toe. And then what you can do is you can stabilize with your thumbs on the arch and gently push down on one side and the other. And what you're gonna do is you wanna appreciate the difference in motion if there is any. I personally, when I mobilize and I try to feel for mobility, I close my eyes. Because you can trick yourself. Don't look, right? Don't look, feel. So if you close your eyes and you push down on one side versus down on the other, see if you feel any difference. Now on my left side, when I did this, there was a severe difference, a significant difference. My first ray would not come down. It was stuck up. I don't know how long that was there for, but it was definitely not able to come down. Now, let me tell you what I did. I had to hobble over to the couch to do this. I remember it was how bad it was. You know, desperation caused a lot of things to happen. And I remember I hobbled over the couch. It was significant pain. I was like, let me just figure this out. So I did this and I felt there was a definite difference. I'm like, well, that makes sense. So what did I do? Well, I mobilized the first fray. Now the first fray technically is a little more in the forefoot. That's when you have the cuneiform, the medial cuneiform, and the first metatarsal. But what I did, and you could do it just the way I explained to check mobility, is you put your thumb over your arch and you use your fingers, it could be on the same side, and just push down. And I just started mobilizing. I spent about 5 minutes. All I did was mobilize my first fray into plantar flexion, into pronation. Try to bring it down to the floor because it wasn't on the floor. I'll go over why that's an issue. So I did that, and I said, all right, well, that felt better. It feels like it's moving better. And I stood up, I walked to the other side of the room. And this is the first time I've been pain-free in years. And I was shocked. It's like, oh, it must be inhibition. It must be placebo. It can't be. It's impossible. So I did a little more, and I did it for a little bit longer, and I actually felt pain-free again. I'm like, okay, this something's going on. The other technique I did, which I'll go over why a little later, is I did ART, a pin and stretch technique for the flexor hallucis longus in order to get great toe extension. We'll go into that a little bit later, why. These two techniques, just to give you an idea, again, this is over 2 years of pain. I not only was pain-free when I started walking, I felt just about pain-free the next morning. And of course, granted, I did these mobs every day, okay? But I only did these two things. I wanted to make this a case study because I was really shocked how quickly it worked. And essentially, I did those two techniques only, nothing else, no icing, no modalities. And I basically over the next 2 weeks was 100% pain-free. Now, I wanted to wait a few months to see, hey, maybe something came back. Maybe something happened. I didn't change my shoe wear. I didn't change anything. I just did these two things. And this is my outcome after multiple years of pain. So I'm going to describe why I feel this worked and how you can look at this for your patients. So in order to describe the ins and outs of why this happened, let's just go over gait mechanics real quick, okay? So in gait mechanics, what happens normally? Your heel strikes, right? When your heel strikes, you have a slight amount of eversion of the subtalar joint, the calcaneus. When this eversion, let's just call it pronation, it's the beginning of pronation. When that eversion occurs, it slightly adducts or drops that talus down. That unlocks the talonavicular joint, which unlocks the navicular cuboid joint on the other side, which unlocks the navicular cuneiform, and that unlocks the first ray. This right here is the beginning of pronation. So when somebody has a rigid rear foot varus, where that thing does not move into valgus, into eversion, it's very difficult to unlock that foot. So the first thing we look at is, can that unlock? Does that unlock, and can we pronate? Because pronation is important. That's your shock absorption. So when you have that pronation occur, what happens next? Next, you need to control that motion, right? Remember the posterior tib? That has to control pronation, which allows for the tibia to internally rotate. Remember that pro volleyball player did not internally rotate. She did not unlock. That was the issue. And then pronation ends at mid-stance. So once you get to mid-stance and you start coming up, that's when you need to control supination. Okay, so when you start resupinating, this is the windlass mechanism, which we'll talk about after this. The common dysfunction is you don't evert the subtalar joint, or you don't resupinate at mid-stance. Those things you want to look for. You don't evert, which means you can't pronate subtalar joint, or you can't resupinate at mid-stance. So the windlass mechanism. So let's go over this. This is important. This is essentially, and this will describe why the treatment I did. But can you see here, these points? What happens when she comes up? You see here, you have these points here. If you measure those, and they did measure in this study, this comes closer together, right? That's due to the plantar fascia and plantar aponeurosis. When you come up, you resupinate, and this locks yourself into supination. If you have a severe flat foot, you might have torn through all that soft tissue, and you might not resupinate well. And that's a problem. That's what we definitely look through the orthotic route. but you need to have that resupination. Now, why, look here, why did I have to do flexor hallucis longus pin and stretch? Notice what happens here. So you have great toe extension. Where is the weight? On that metatarsal head. Very important to look at. If you didn't resupinate, where would the weight be? The weight would be off the edge of the phalange. Now, if you look at your feet, look down your feet, look if you have any calluses. Do you have any calluses on your big toe? I mean, take a look. On the medial side of your metatarsal? I do. That's exactly where I push off. So all my push off has been through here. Now, when I stood up and tried to push off normally after that mob that first night, I noticed I felt a deep pull underneath here. So was I going to get full great toe extension? No, because I haven't used it for a while. So I knew I needed great toe extension, so I had to loosen up the soft tissue underneath. And that's why I did the flexor hallucis longus ART. Very important point. Will joint or soft tissue restriction will allow movement to occur if you have a strong muscle. So here's an example. Let's just say you have an elbow that is restricted because of a joint issue, right? And you are the strongest person alive, and you have these giant, massive biceps, and you say, I don't care, I'm so strong, I'll push through it. You will never win. If you have a restricted tricep, and it's scarred down or really hypertonic, and you have a huge bicep, and you try to bend that elbow forward, you're never gonna bring your hand to your chest. The reason being, joint and soft tissue restrictions will always win over strength. So our job as PTs is we have to eliminate the mobility issue. We treat that first all the time, and that's what I had to do. I had a first ray that was stuck in dorsiflexion and was rigid, would not come down. I had to pull that toe down and that first ray down to touch the ground. Then I can work on motor control. So what do we need to do? What's our goal? You can see here what we need to make sure in a normal foot, normal mechanics, the fifth and the first metatarsal heads have to touch the ground. That's the key. And the medial and lateral calcaneus. If these aren't touching, and of course you end up going across all the metatarsals, if these aren't touching, these two, they eventually have to come down. So this toe will have to come down eventually, but that's going to change the mechanics of the rest of the foot. And that was happening to me. This toe was elevated. So when this foot is elevated up, this medial side of the foot is elevated up, when it comes down, it contacts through here. So all the force was distributed from the second and the third metatarsals. All right? So this was the issue. If I were to get this first ray down, these would absorb the force as much. I could change the biomechanical stress by changing the response through the mobilization. And that was without an orthotic. Let's keep that in mind. I did not use an orthotic to change things. So this is where I think it's really interesting. And I've been working on this theory for probably at least 10 years. And those who work with me know I tell this all the time from a neuro-orthopedic point of view. But this study looked at Lodi taping. So that's essentially you taping the arch to improve the arch for antipronation purposes. And in doing so, it sort of mimics what an orthotic would do. And what they found with this Lodi taping is it caused a delay in muscle activation in the glute med, vastus medialis, and vastus lateralis. This is the Journal of Orthopedic Sports Physical Therapy. So this is where there's many studies that look at things like this. But the studies consistently show when we make a change to the foot, there are muscle changes, muscle activation changes, muscle strength changes. And traditionally, years ago, we thought this was all due to biomechanics. Well, you're changing the arch, and that is more rigid, and that changes the tibia, and the tibia doesn't pronate or internally rotate, and that changes muscle activation. And that could be true. But what we're leaning toward, and these authors are leaning toward, that it could be secondary to neuromuscular regulation. And this is where we need to look at the foot and why the foot will impact the proximal extremity. So let's talk about orthotics. Now, there's many studies that talk about orthotics. Here's just one that goes over, there was a significant change in patellofemoral pain with an orthotic, right? They just know that antipronation foot orthoses help with different primary pain issues like patellofemoral pain. Now, is this due to the mechanical control or is it due to proprioceptive feedback? Now, keep in mind that last study, they did sham taping. So if you're thinking, oh, they taped the foot, which caused a sensory response, that sensory stimulus won't change activation of muscles. Yeah, that could be, but they did sham taping where they had tape without directional changes. So that might negate that possibility. But when you have an orthotic, what's happening here? What are you doing? So here's my case example. This is a different pro beach volleyball player. She also had a rigid foot, not like the other one I showed you, okay? But she had a rigid foot, and she would come in with significant patellofemoral pain to the point where she really had trouble playing in tournaments, volleyball tournaments. So there was two ways to get rid of her pain. So when your patient walks in with patellofemoral pain, first thing I do is I check the foot. Now, what you can do is you can prop the foot up. You can give it you can take an orthotic, you can put it in their shoe, have them squat or similar squat with and without it and see the difference. You could take a towel roll it up under their arch, give them their quote unquote arch and see what happens. And you can see that can significantly change their knee pain. So with this patient, we did that. Now the problem is she's a beach volleyball player. If I had an orthotics all day, that would be great, but she has to play on the beach. She can't wear shoes. So what I would do is I'd mobilize her foot. I'd do pronation moves. I would get her arch down to the ground, and we were successful in doing this. Well, I would do this. She'd walk in with pain. She couldn't squat. I would mobilize her foot for a few minutes, and her knee pain disappeared. And it would stay away sometimes for an entire tournament the next day. So what is going on here? Why is an arch support that holds your arch up have the same impact as pronation moves? And my feeling is, and this is evidence-led, okay, my feeling is that when you get sensory input to certain parts of the foot, that is going to send an afferent message to the brain, which will send an efferent message down the extremity, down to the leg, down to the knee, to the quads, to whatever muscle we're talking about, could be gluteus medius, and that'll change the mechanics from that point forward. So the fact that we can mobilize a foot has the same impact as keeping the ground up to the foot. Both are getting sensory input to the bottom of the foot. And that is what we're looking at. Why did my first ray mobilization work for my foot pain? I got my toe down to the ground properly. That's what my brain is supposed to feel. When it came down, that changed my motor response and changed how I walked immediately. I felt pulling underneath my toe. I mobilized the soft tissue underneath here, got full great toe extension. I was automatically able to have a proper gait pattern. I told you, I tried to walk with a proper gait pattern in the past. I tried doing push off of my big toe. Did not change a thing. So it's not just about your brain thinking it. You know, I have an example of the motor control system I always love using. I'm really big into Halloween. My house is decked out. I have this one thing where when you walk into my front of my house, front door, I have under the mat like a little pad, and when you step on it, it makes this sound, right? Loud, obnoxious, screaming sound. I hate it. I got rid of it, by the way. And I remember one year I had it, and for the first like 3 weeks, every time I'd step on it, I mean, I would jump, right? So obviously what happens? My brain says don't step on it. So I start stepping over it after a certain amount of time. Now, I got rid of this after Halloween, and wouldn't you think my foot would go back to stepping on that mat? I mean, I consciously know Halloween's over. There's no decorations. It took me 3 weeks to start stepping on the mat again. The reason why I'm bringing this up is because our brain is going to avoid pain. In this circumstance, the pain was a screeching sound, which obviously my brain didn't like. That input upregulated my sympathetic nervous system, and I had an automatic response where I didn't think about it, but I changed my gait, which was stepping over this mat. How long did it last? I had to take 3 weeks to tell myself, just step on the mat again, it's okay. So you can see how if your brain senses a stimulus like pain, it will find a way to move around that pain. It will find an alternative route. And that's exactly what happened to me and what happens to your patients. They have pain in the talocrural joint, like I did. They're going to find a different way to walk, and they have pain through here. and they'll move away from that, and they'll have pain through here. So the moving pain, don't follow the pain. Follow the mechanics. That's the point. So quickly, let's talk about cuboid syndrome, because I'm sure you might have this with some of your patients. This is something that we miss, okay? When you have a lateral ankle sprain, you roll your ankle, right? What happens here is you have the peroneus longus, and there's a groove, okay, that is right at the cuboid. This groove, when you roll your ankle, this peroneus longus is trying to contract. It's trying to stop you from rolling your ankle. That's its job. Let's say it doesn't do it. It's still on. So what happens when you roll your ankle this way, this pulling force can pull that cuboid externally. So everything rolls down, rolls over, but this goes the opposite way. So you're left with a cuboid that's sort of stuck with a hypertonic, a toned up peroneus longus, which really tried to do its job and couldn't. So it doesn't really go away. These are the patients that after ankle sprains, some might say they have pain over their cuboid. Some might have prolonged pain. I mean, it could be months and months of pain over the latissimus. Some might have pains of the tendon or the muscle belly. So if you have a chronic peroneus longus issue, check this. Usually when you mobilize the cuboid, it hurts. A hop test is usually painful or they can't even do it. Now, when we talk about instant results, this is what we're talking about. Here was a study done. George Davies is a very well-known PT, does a lot of research and publishing. He did a study where he looked at 104 ankle sprains, all right? Of 104, only 7 of them were treated with the manipulation. And we've gone through in the past the manipulations that we do for cuboid. 2 of them had to walk in on crutches. Now, they all had serious enough injuries where they weren't better, okay? Many were well past their ankle sprain days, okay? So this is not they sprained their ankle and 2 days later they are having issues. This could be much later. It was chronic. Now, when he did the manipulation technique, all of them, the ones who were in significant pain, all were able to return to sport that day without pain. And they followed up over the next few months, and pain never returned. When you ask yourself if one manipulation or mobilization can change pain, this study here is one example of that. Patients walked in, young athletes, in on crutches. One manipulation, they returned to sport that day. So there is an impact. Now, this doesn't work in everybody. If you did this on 104 people, only 7 of them had an impact. So not every single patient needs it, but when you pick the right patient with the right pathology, with the right biomechanical issue, the results can be this quick. So this is just a quick video I show you. Just to, your thumbs are over the cuboid. You just do a quick thrust. If it's a lateral ankle sprain acute, you would never do it this way because you're going to put them into inversion. We've gone through this before. There's multiple techniques you can do, but a cuboid mob can help. But you want to try to push that cuboid so you're pushing it into internal rotation. So you're pulling it so it comes up to the arch, right? Okay. We're getting close. Hopefully you're hanging in there. So range of motion. The few things we're looking at, I think is most important for walking, we need 10 degrees of dorsiflexion. Now, I know I say it's 10 degrees, and that's what the literature shows. But when you measure somebody, they better have more than 10 degrees. Yes, that's what's needed, but that's the bare minimum. 20 of plantar flexion, 50 to 60 of great toe extension. And we'll talk about how we measure these. This could be up to 70 or more. Now, when we measure, we use the 3D infrared analysis, which makes this job much easier. Back in the day, this is the way I would do it, but you can see that studies show that the weight-bearing lunge test is way better than measuring otherwise. And when we learn in PT school, we learn dorsiflexion is 20 degrees, but we want to look at weight-bearing. So when we measure this, you can see that we're measuring dorsiflexion weight-bearing. Now, what do we want there? Without the heel coming up, we want 42 degrees. That's sort of the measurement. If they have 10 or 15 degrees here, that is an equinus foot. Not good, okay? But that's more for a squatter for sports or for somebody who has a job where they're squatting down a lot. If we look at dorsiflexion here with the leg straight, right, the knee not bent, again, heel stays down, make sure they're centered. They should have about 36 degrees. Now, when you measure this, if you see that they have 15, 20, 25 degrees here, you need to make sure that you ask about the quality. It's not about the number. Check bilaterally, because if they get 15 or 20 degrees of dorsiflexion, you might say, yeah, that's enough. What does it feel like? Let's go back to that example with the brain sensing pain. If you have restriction and you get through that 10 degrees and you get there but is still restricted, what's going to happen? Your body moves through the path of least resistance. You're going to change your mechanics and move around that. So even though you might have enough range technically, ask about the quality. What does it feel like? They have pulling back here. They should feel no pulling in that 10 to 20 degree range at all whatsoever. They shouldn't feel pulling until they get to the 30s. So make sure you look into that. If that's an issue, change that, and that can change the mechanics of the entire foot. And then we have great toe. Now, obviously, for great toe extension, I like to do weight bearing, right? You can see, again, you want that range here, but remember, if you check them on the table and their foot is plantar flexed, you check great toe extension. That is very different than a weight-bearing great toe extension. So if you're going to check them on the table, make sure you have them in dorsiflexion. Think of the different fascial planes. You need them in dorsiflexion in order to replicate what's in weight-bearing. So make sure you check them in dorsiflexion, and you want that 50, 60 degrees. Eversion. Now, the 10 degree, the literature said it's there. I don't see 10 degrees, true 10 degrees of eversion. I see 0 to 5. Sometimes you don't get to 0. Those are the problem ones. But we want to make sure we have eversion, because again, what is the subtalar joint, the heel? When you evert, that unlocks the rear foot, which unlocks the rest of the foot for pronation. Then inversion, eversion, this is just a subtalar joint. That's 20 to 30 degrees. So what we're looking at. All right. So wanted to look at the techniques that we do for treatment, right? So ART, active release technique, pin and stretch. If you have a gastroc soleus issue that's tight, people make their careers off ART. There are some practitioners, chiropractors, massage therapists, where all they do is ART. Do you know why? Because it works, right? It definitely impacts the sliding of that tissue. You get some great range because restriction is going to impact biomechanics. What else can it do? It can affect tone. This is where I know I obsess about it, but we're looking at tone. We're treating tone all the time. So you can get fascial changes, muscle, tendon, nerve, but it also helps with tone. So I'm a big fan of ART. You can do it on any muscle, on any tendon. Then we look at motor points. Again, tone. Now, when you look at the muscle spindle fibers, those muscle spindle fibers are what regulate tone. So I want you all to stand up, and I want you to feel what you feel when you're standing. If you're standing up naturally, just notice, is your weight on your heels? Is your weight in the middle of your arches? Or is your weight toward your toes? For those of you, which I bet it's quite a few, your weight's on your toes. So when your weight's on your toes, what's happening every day, all day? Your gastroc soleus complex is on. You're essentially telling the muscle spindle fibers, which regulate tone, you're telling them to stay on. You're giving them input that has to be on all the time. Then when you lie down in bed, guess what? They're on. I think of a dimmer switch. That dimmer switch is all the way up on high, and it stays that way. And then you have to inhibit this tone. Motor points is one technique to inhibit tone. That's very effective. If you have an arch that is a flexible arch that falls quite easily, what muscles hold that arch up we talked about? The posterior tib. If you have a posterior tib that's constantly on, it can't do its job properly. It's just trying to hold up the arch. And you work on motor points or inhibition, that can change biomechanics as well. So again, make sure we're looking at our motor points, make sure we're looking at inhibition. If a muscle's always on, you need to regulate that tone and reset it. And resetting tone is one of the best ways to get success. So you can see here we have Grasson techniques. You can see you work on plantar fascia. If you have a restriction, you can see you can work on the Achilles tendon. Very helpful, very beneficial. Works really well for certain restrictions. And then we have cupping. Now, what I like with the cupping is not only do we get some help with just the pulling with the cups and the superficial layers of tissue, but you can see how we like to move the cups back and forth. But I really like doing it also is exercising with them on, not for too long, just for a short period of time, and make sure it's not too tight, okay? But by stretching and pulling on tissue versus pushing down on tissue, we get good results. You know, we're used to pushing tissue down, right? But what if we pull tissue up, finally changing that pressure change? And this can have a cellular change between tissues. And if we can get that cellular response to occur, we can increase flexibility. So the fact is it works really, really well. So that's another technique we use for our foot and ankle. This is one of my pro baseball players. Obviously, it's a lot of cups, but we got some really great results on quad flexibility from just working with some cups. And then joint mobs. You know, when we do joint mobs, here's a talocrural joint mob. We're trying to stretch capsular tissue, right? That's usually what we're looking at. But the other thing we want to keep in mind, we might be trying to inhibit some pain, okay? If you want to get a good mob, it feels like the capsule stuck, I like this belt technique. The belt technique is tractioning the talocrural joint and posterior gliding. And if we hold it with a prolonged hold, that will deform collagen, which is really what we want to do if we have a capsular issue. And then here we want to work on trying to get pronation moves to the midfoot, okay? Talonavicular, navicular cuneiform. You could also use weight bearing as well, very effective. With mobilizations, depending on what part of the body, remember, we could also be impacting peripheral sensitization and central sensitization. I won't go into too much detail, but essentially, your nociceptors are giving false information to your brain. So you're feeling something different. So when you have that patient that walks in that says, man, the outside of my ankle or leg is just a touch, it hurts. That is possibly peripheral sensitization. They could do well with mobilizations just to inhibit that, just to make changes. So you have to treat the neurological system with something like that. And mobs and manipulations are one way to do that. You can see here, this is the manipulation, very effective after ankle sprains. We also have down here, looks uncomfortable, but you're tractioning, you're distracting the tib fib joint, try to give space at the talocrural joint, right? So you could also do this and just do a prolonged stretch. You just hold the tibia and fibula, the malleoli, spread them as you're trying to get dorsiflexion. And again, these help with neurophysiologic effects of tone. That's what's great about the manipulations is they really are helping on a neuro level. And of course, active muscle pumping, you know, posterior chain, you know, trying to have them contract and then relax, increasing blood flow, decreasing tissue tone, you get neuromuscular education, all really helpful. And then kinesio-taping. What do I like about kinesio-taping? The somatosensory system. The receptors are going to feel the tape, which can change motor output. That's why I like it. That has many purposes, but that's why I like it. Make a change the neurological system. And basically, if we look at taping, we didn't mention syndesmotic sprains, but let's not forget that when you have a syndesmotic sprain, you splay through the tib-fib joint, right? And you actually tear through syndesmosis. If you tape them, that could eliminate their pain. How you test for that is you can dorsiflex them, which could cause pain here. Also, you can prone, knee flex, push through the calcaneus into the talus, right, through the calcaneus, and slightly internally externally rotate, and that'll splay it, which will cause that pain there. With taping, you can also put tape on the malleoli, pull it back around the backside of the leg, and when you do that and you cross it around, what can happen is you can now dorsiflex and you get motion and you're self-mobilizing. You're getting that gentle, slight pull of the malleoli, distracting as you dorsiflex, and you could get some better mobility there. We've seen that clinically work pretty well. And then we talked about lodi taping, taping the arch, and the orthotics. So a couple exercises, we're almost done here. Just want to go over again, we talked about what do we want? We want eversion of the subtalar joint. So you can get your towel on the lateral side of the foot and pushing down. And then we want to have pronation of the midfoot. So you can go over the forefoot, stabilize it, and try to get pronation through there. See how he's lifting up there? That's not what we want. We want the motion to come from there. And then great toe extension. This is really important. Remember, this is that windlass mechanism, right? Look how his great toe is over that towel. You're already in probably 20, 30 degrees of extension, and you're moving over it. You should feel a good pull. You're self-mobilizing the soft tissue on the plantar side of the foot. And then once you do that, so with a foot that has a medial heel whip, look here at the band. Keep the band under that first med head. Walk and try to go over and keep that down. What's that going to do? Sensory input to the brain to keep that med head down, and you keep it down as long as you can, and then you lose it. And then hopefully you can replicate that when you're walking, so you're pushing off the big toe and not off the side of the toe. And then for ankle sprains, I throw in a little bit of exercise here. I don't really love just doing eversion TheraBand. So here's when you have TheraBand and it's pushing into eversion, but also the whole posterior chain's working. Your pelvic tilted, you're lifted in the air, glutes, hamstring, everters all on at the same time. And when you have later on you're rehabbing your patients who have ankle sprains, force them into supination. Make them go in that position and force them to control it and come back. Once that big toe comes off, they have to pull back. So get them into further and further and pull down. That's not great form. Yeah, not great form. But that's the goal. He wants to control that motion. And for home, what do we do is, RDLs are just good to make sure, again, you're stabilizing. Always want to keep in mind, keep that great toe down, keep the heel down, keep that fifth met head down. And the last thing I want to go over sort of reinforces what we've been talking about is orthotics, right? We did immobilization to get the foot in the right position. Now I haven't been wearing my orthotics. I don't feel like I need them. I'm 100% pain free. I have no pain at all, which is shocking after a few years. But I will be putting my orthotics in and making sure I'm molding them into my shoes separately. Remember, the advantage of the orthotics we use is that you are molding them into a shoe. Now, when you get a hard orthotic, a firm orthotic, or one off the shelf, you're putting in the sneaker that already is meant to give the foot anti-pronation abilities, right? You already have an orthotic within the sneaker. And then you put an orthotic on top of an orthotic. So now you're in further inversion. If you had an ankle sprain and you had an osteochondral lesion on that medial talar dome, and now you're in too much inversion, you're going to make contact constantly over that medial talar head. You're going to have that pain consistently. So what I like about the orthotics is we heat mold them so you can bring that down. So even if you have a shoe that has its own correction, you're not double correcting. You can add your wedges. You can add a medial post to the rear foot. That really helps with pronation. So when you have your patients who severely pronate and the orthotic doesn't quite do the job, look at the rear foot. Post the rear foot, something who really flattens out so they don't come down quite as much. Then, do you post the forefoot? That's the question. Very rarely would I post the forefoot. We saw what happened in my experience. If somebody has severe pes planus, flat foot, you can try it, but make sure you look at the mechanics above. And what I think is most important is the orthotics have shock absorption qualities. The most recent Cochrane Library reviews on the efficacy of custom foot orthoses conclude there is gold level evidence for treatment of painful pes cavus, which is that high arch, and silver level evidence for foot pain like plantar fasciitis, rheumatoid arthritis, and hallux valgus. That's pretty good considering there are so many different kinds of orthotics out there, some great, some not so great. So that's actually a pretty good review. But what I want to leave you with regarding foot mechanics is, what is the orthotic doing? Again, the orthotic, if it brings the ground up to the foot, is it the shock absorption? Maybe. Or is it the proprioceptive feedback to the brain that allows an efferent motor control message back down to the leg? That is the question, and that's what I want you to look at when you're thinking about what is the benefit of an orthotic or mobilizing the foot, or making sure that the rear foot and the first med head and the fifth are on the ground at neutral, right? And during gait pattern. If you look at that, I think you'll have a whole different outcome in your results. The one thing I want to end with is just reminding us about the pool, right? We have pools at all our clinics. Why not get a patient in? Doesn't mean they're a pool patient because athletes can be in the pool. But when you're in the water, now you're not weight bearing. Now you're taking that tissue injury that needs some time, and you're letting them, even if they're weight bearing in the water, it's less weight bearing, right? Less pressure, less compression. They have tons of lubrication. They're using their core. When their core is on, they're stabilizing. And there's so many studies that are linking core stability to success of extremity issues. We all know that. If their core is not on, you know that those patients fall forward and they go into anterior pelvic tilt. So obviously, that core has to be on the whole time. And that's going to help with their outcomes as well. So it could be that you have a patient, you see a few visits, and they do one visit in the pool. I just want to make sure we're keeping that in mind with our visits. So the summation is, after all that, I just want to make sure that we aren't just following the standards. We want to be better than that. We don't want to just say, hey, the gold standard is these 5 treatment approaches, and that's what we're going to do. When you have it, that will work for 80% of your patients. But when you have a patient that's stuck, and you have somebody that's gone to see other PTs, who's done PT, my favorite patient is one that's already failed PT 2 or 3 times, because I'm not going to do what's typical. And that's when I'm like, well, let's figure this out. What is happening on the biomechanical chain? What can I change? What can I work on differently? And that's when I want you to really make sure, and I know we do this, and I want to continue focusing on it, but really looking at the biomechanics of that specific person. If they're not better in a short period of time, what are we missing, and what biomechanical changes can we make to help them improve? Thanks for listening. Sorry it took so long to get through that, but are there any questions at all?
Oh, hey, Kahl, I got a question.
All right.
Can you hear me, Kahl? So
yes, I can hear you.
So you had your anteromedial pain in your talar curl joint. Is that better now? Because that caused all the second MTP, but what about your ankle? Because your stuff addressed your forefoot. Is your ankle pain better now, or how'd that work out?
I haven't had ankle pain since. I think I should have addressed this issue a long time ago. I never did. I have no ankle pain. I have no foot pain. I have no midfoot, forefoot pain. I'm pain-free now. If I put an orthotic on where I'm in too much rear foot inversion, I absolutely start having some pain in my medial talus. That pathology didn't go away. I still have an osteochondral defect, but I'm not hitting it. I'm not continually irritating it. So I think that's what's helped.
Got it, because you change the way you walk, you change your biomechanics, you're not stressing it as much. So while there may be a problem, you've learned to kind of live with it by restoring normal biomechanics.
Yep.
I get it. I like it. That's really good.
I feel like that's the key. That's what we do. Like when I have patients say, hey, I have arthritis. This is not going away. I say, you're right. We're not changing our arthritic change. But if we could change how and where we attenuate that force, if we change which part of that joint is now absorbing force, wherever that lesion was, we're not hitting it. So there's no inflammation. It seems like magic sometimes. Like, I can't believe it's gone. I have this major arthritic change. You're just not hitting anymore.
Got it. No, I love it. That's great. That was really good. Thank you so much.
Good, thanks. Any other questions for you guys before Dr. Austin goes